Welcome back to COVID Sense. The goal of this channel is to help you understand the evidence so you can make informed decisions regarding COVID. This is the second segment in our series on informed decision making. Today we'll be talking about COVID and children under 18 years old. We have Deanna McLeod, Principal of Kaleidoscope Strategic, to walk us through the data. Deanna has a degree in immunology and more than 25 years experience preparing evidence-based drug evaluations. So what do we need to know about COVID and children?
So NACI, or Canadian National Advisory Committee on Immunization, began recommending vaccination for children aged 12 and older on May 18th, so just recently. This change was based on results from biotech phase 3's extension trial enrolling children aged 12 to 15 years. And that study reported that vaccines were safe and effective. So NACI, although they acknowledge that youth are at low risk of severe disease, they do recommend vaccination in this age group to reduce transmission. So with that, the big question for parents with teens is, should we be vaccinating our children? So the question here is multifactorial. So at best, what we want to be doing is weighing the benefits and the risks. So the first question that we have to ask is a series of questions regarding the risk of disease. So those have multiple factors. So we have exposure is a consideration, severe disease, transmissibility, and non-treatability. So all of those would put somebody at greater or lesser risk of severe disease. Then we have to consider the vaccine. Is it able to lower severe disease, and has it been tested and proven to show that it can reduce transmissibility? Third, we want to look at adverse effects. So there's immune training that's involved with an infection. And then in terms of the vaccine, there's long and short-term adverse effects. So all of those would kind of give us a sense of the net risk. So a decision is good when the benefits outweigh the risk, and it's probably a no-go when the risks outweigh the benefits. So let's take a look at the data and see what it can tell us. So what we're looking at here is the Canadian COVID statistics from March 2020 to February 2021, so about a year's worth of stats. And what it does is it breaks down cases, hospitalization, ICU deaths by age group. And so on the left here, what you can see is the age group for less than 19 years, which is our target group for children. And it's mapping out the cases per 100,000, or the numbers per 100,000. And so here what you see is this number is the number of adjusted cases. So that means that it's the number of reported cases adjusted for seroprevalence, which means basically that it's known that there are more cases of COVID in the community than what were reported. And so it adjusts by a factor of 9.1. to give you a better sense of how many people have been exposed to COVID. And so based on that calculation, about 12,000 per 100,000 kids have already been exposed to COVID and are immune. So that's good to know. And of those 12,000 that have been exposed and recovered, only 10 out of 100,000 have actually been hospitalized, and 1 out of 100,000 have died from COVID or have been admitted to the ICU, and 0 have died. Based on those statistics. So overall, we would say that the chance of severe disease for children less than 18 years is quite low. We also know that the majority of the deaths that did occur all involved comorbidities. So other conditions were at play that were predisposing those children to severe disease. So average healthy child, very low risk of COVID. Severe disease. Now, why is that? And a lot of what we can understand, it goes back to immunology 101, and that's remembering that we really have 2 branches of our immune system. We have innate immunity and adaptive immunity. And so innate immunity is kind of like the rapid first response team, and the adaptive immunity is like understood as target, clear, and remember. So if you were thinking about, a club, at the door to the club, you basically have a couple of bouncers, and their job is to make sure that the riffraff don't get into the club and disturb the experience for the clientele. So when working at their best, the muscle keeps the riffraff at bay, and everybody enjoys their experience. However, it is possible that somebody gets in, and at that point, we want to have a system that basically identifies them as an unwanted, and basically is able to call the bouncers to remove them from the club. So that would be the adaptive immunity. So both innate and adaptive immunity are important in fighting infection. And so when it comes to COVID-19, we basically have a youthful system here on the left. And in this system, basically, as the virus arrives in our respiratory tract and starts to penetrate our mucosal membrane, then the first line of defense, our innate immune system, basically identifies and clears the virus before it can replicate and before it can really infiltrate our system. However, it is possible that some viruses do get into our respiratory tract and move their way up into our lungs and the epithelial cells of our alveoli. And at that point, what we want to do is we want to have the adaptive immune system kick in and identify the invader, tag it with antibodies, and call the innate immunity or coordinate a line of defense to remove the virus. So in an innate immune system or a strong, healthy immune system, you've got strong first-line defense and you've got strong adaptive immunity that's able to clear the virus if it does infiltrate. So what this really means for youth is that the virus is less able to replicate. And if it is less able to replicate, then that means lower transmissibility and ultimately less opportunity for mutations. So, we like our kids and we like their immune system because they're like Pac-Man and they remove the virus from circulation. Another thing to remember is that this whole coordinated response between the adaptive and innate immune system is tucked, the battle plans are tucked into our immune library and they're remembered by our T and B cells. And so then what it's doing is it's training our immune system to know how to fight coronaviruses. And that's all tucked away in the library. And the next time we meet a coronavirus, we'll be able to recall that strategy and implement it, deploying antibodies as needed. So I think the reason why our kids are doing so well is they really have strong innate immune systems, and it allows them to coordinate a well-balanced immune response. So I think we know that basically the kids are at low risk of severe disease, and that's because they have strong immune systems. But if they were to get COVID, would they be able to be treated? So what I'm looking at right here is the results of a meta-analysis of randomized controlled trials for Ivermectin. Now, Ivermectin, you may or may not have heard about it. It's a little bit controversial. I'll explain why. But basically, the randomized controlled trials that were conducted are listed here, and some of them were conducted for early treatment, and some of them were conducted for late treatment. And in the results, this is a plot here of hazard ratios. And so you can see here that this is unity, meaning that there was zero benefit. And if the boxes are to the left here, that means that there is a benefit. And if their boxes are over here, that means that the control had a benefit and the agent didn't work. But you can see here, especially when it's introduced early, that it is a very strong and robust response. It's consistent across randomized controlled trials. And when you sum those all up, it's about an 80% improvement in outcomes. So even if your child were to come down with severe disease, there are interventions, especially that if administered early, could be very effective. So here's another list of randomized controlled trial with measuring late benefit, and you can see that there's a little bit more noise here in the trials. However, when you sum them all up, again, what we're seeing is a really strong benefit for ivermectin over controls. So ivermectin has been around a long time. It's been used for treating parasitic infections. It has 25 years of safety, but it's controversial mostly because a number of countries have basically said that it shouldn't be used. And it's a little bit political because it's not for lack of evidence, because the supporting evidence is there, but more because if there was an effective treatment, then the regulatory mechanism by which we're accessing vaccines, which is an emergency use status, would be revoked. And we would no longer have access to vaccines. So there's definitely a political will to try and suppress ivermectin data because If they did that, the vaccines, which are experimental, would no longer be used, or we no longer have access to it. So let's talk about risk of disease. We've covered a lot of data. So here, the first one is exposure. And I think if we were to try and address the question of exposure, our kids are likely going to get exposed to the coronavirus because they're at school and interacting with their peers. Are they at risk of severe disease? I think the answer would be no. Transmissibility, are they able to transmit the disease? I don't think that there's any good studies that show that they're high transmitters, and the biological argument could be made that they would have low transmissibility among anybody. And in terms of treatability, they're definitely treatable should they get coronavirus. So overall, I would say the risk of disease is low. So I guess that would be that. So let's go on to the next step. What can the vaccine do? So the vaccine basically teaches your body to generate a pathogenic protein called a spike protein. And so basically they take the spike protein here, they code the mRNA, and then it's encapsulated and introduced manually into your system. It then goes throughout your body and enters cells of all descriptions, especially those, and then it basically starts to produce this spike protein. It teaches your body to produce a spike protein, which then is expressed in your cells, and your immune system comes along, identifies that as foreign, and develops antibodies. One problem with the whole thing is that the spike protein itself is pathogenic. It's able to turn on inflammatory pathways, and it's also prothrombotic, meaning that platelets have high expression of ACE2, and the spike protein can bind to the ACE2 receptors on the platelets, and so it causes them to be sticky, causing coagulation in some people. So we do know that this spike protein, which the body is being taught to produce, has pathogenic qualities in and of itself. So let's take a look at the vaccine trials. So this is a classic randomized controlled trial. This is similar to the one that was conducted in adults, where you have 2 doses of the vaccine versus placebo, a few weeks separation between 2 doses, and then 1 week, and then they start measuring things. Now, in this particular trial, they didn't actually have a clinical endpoint. They had a laboratory endpoint. And what I mean by that is they randomized 209 people to the vaccine and 35 to the placebo. And then they looked at how many antibodies the person produced. And then basically, if that was comparable to the cohort of between 16 and 25 years in the adult trials, then they said that the vaccine was effective in this group. So one of the things that we need to really recognize right away is that there is no clinical endpoint. It's not measuring the efficacy of controlling disease at all. It's basically just a seroprevalence endpoint. Now, they did do an endpoint where they had a clinical description. They did have a clinical endpoint, but it was for descriptive analysis only. We can't actually draw any causality from that. And that was done in a larger cohort, about 2,500 people. So we do know that primary endpoint was PCR positivity and clinical symptoms. So we know that for kids, the clinical symptoms are mild, and then it's accompanied by a PCR test that's positive. So when they did look at that, we'll look at the outcomes for that. We know that we can reduce PCR positivity. However, this study was not designed to assess clinical severity of disease, utilization of resources, or death. It definitely wasn't designed to address issues of transmissibility, and its ability to make any conclusive statements about efficacy in subgroups is limited. And I think the greatest element to be recognized here is that the data for this trial is unpublished, meaning that it hasn't gone through peer review. The reason why I have access to this data is that I actually pulled the FDA documents. It was a memorandum for review of the vaccine in this age group. So what that means for you as a parent is that when you go to talk to your doctor about this particular vaccine, they may or may not know the details of this particular study. So it'll be really important to bring it up and to discuss it with them, because they might not be aware. So outcomes. Well, the main outcome was laboratory values. Was it able to produce antibodies in kids? And the answer was yes. The second endpoint was clinical benefit in the sense of positive PCR tests. So this map here, it looks at the net cases or net events. So either the reduction in cases, which would be a net reduction of 1,600 cases per 100,000 with full vaccination of all children, 1,600 would benefit out of 100,000. And what the vaccine will do, though, is it will actually cause COVID-like symptoms or adverse outcomes in 42,700 kids. So low positive PCR tests and mild symptoms here, and any number of moderate, mild, or severe adverse events caused in 42,700 kids. So what do those adverse events look like? Well, they can range in severity from severe, meaning that it prevents your daily activities, moderate, which interferes with daily activities, to mild, meaning it doesn't interfere too much, it's just a slight annoyance. And here we have the repertoire of symptoms, and you can see here that there's quite a bit of pain on the injection site with the vaccine versus the placebo. And you can see here also that all of the COVID type symptoms are appearing here. So it's giving the same type of disease profile as COVID itself, with fatigue, headache, chills, and muscle pain being the worst actors. And in some cases, quite severe in the sense that it's interfering with daily activities or completely limiting daily activities. So in about half the patients for a few of the symptoms that are, or a few of the side effects that are seen. So one of the things that we can definitely say is that if the COVID-19 causes mild disease, then the vaccine would cause probably moderate disease or moderate side effects or adverse symptoms. So those were the main adverse effects or side effects caused by the vaccine. So let's look at some of the rare ones. When you want to identify rare adverse events, what you do is you look at the VAERS database. It's a passive reporting system, and this is the one that was reported for adults because we don't have enough data on vaccination of children at this time because it was just approved. But in adults, we've been vaccinating for about 4 months, and this system has been collecting data. And what we can see here is that of vaccine suspected adverse events that were reported, that basically means that somebody gets vaccinated and a little bit later they're like, hey, I'm sick with this. And they say, I think it was related to my vaccine. I'm going to report it. So we know that the common groups of adverse events are allergenic, neurological, cardiovascular, and coagulative in nature. So we know that it's affecting all of those systems fairly consistently. And we know that of the things that are reported, that the cases, for instance, Bell's palsy, appendicitis, convulsions, and seizures, are basically underreported due to the nature of the system. Because there's no direct mechanism for reporting, it's not straightforward. And because people aren't really suspecting that they'll have any adverse effects, there's generally underreporting. And even with that system, the number of vaccine-related fatalities is basically 4,000 for the COVID-19 vaccines for the first 4 months of the year. And for all other vaccines, there have been 9 fatalities. So you can see that this has got quite a bit more morbidity associated with it than other vaccines. We're not really talking about your average vaccine here. So the last piece of the safety puzzle that we need to address, in addition to regular AEs, rare AEs, is long-term safety. So safety is a really big issue whenever you're looking at somebody who's healthy, who has a lot of quality life years ahead of them. And children probably have, greater than 50 quality life years ahead of them. So what we want to do is we want to basically preserve those quality life years and not introduce anything that could be that could cause injury and impair quality of life long term. So for something that is going to go on for 50 years, you basically want to do about 10 years of safety studies to make sure that what you're introducing is not going to cause injury. And right now, in children, we basically have 2 months of data. So I would say, if the question was, has the vaccine proven its long-term safety? I think the answer would be no. Have they seen that it's safe within the 2 months that it's been studied? They would say yes, although I would say that the adverse effects seen with this particular vaccine are higher, especially the systemic effects, than the average vaccine. So now we're on the vaccine question. So we know that we have a low risk of severe disease. Now, has the vaccine been able to prove that it can lower severe disease? The answer would be no, because that wasn't an endpoint in this study. All that we were able to prove was that we could lower PCR tests and produce antibodies. Was the question of transmissibility addressed in the studies at all? The answer would be no. So we know that it hasn't proven to be able to reduce transmissibility. So I would say that in terms of efficacy, the net benefit at this point, as far as what has been proven in a randomized controlled trial, would be low. Let's look at the risk side of things. So we do know that every time a child is exposed to a coronavirus naturally, that there's an immune training where the innate and the adaptive immune system learn to work together to produce a coordinated response so that it's training the immune system. So I think that would be a lost opportunity with the vaccine. In terms of adverse effects or side effects, I think the side effects profile for this particular vaccine is pretty hefty and would cause moderate disease, where the children would probably be prone to mild disease. And in terms of long-term safety, have they been able to prove the long-term safety of the vaccine? I think the answer would be no. So overall, I would say, given the fact that children have 50 quality life years ahead of them, there is probably a net risk of adverse outcomes long-term and short-term with the vaccine. So when making this decision, it's really important that you weigh the benefits for this particular patient over the risks, and then go ahead with an informed choice that makes sure that the benefits outweigh the risk. So I really encourage you as a parent to take this data that you've reviewed and bring it to your medical healthcare professional and discuss this at length. Thanks for listening.
And one thing to keep in mind is that this data changes quite rapidly, so check back often, subscribe to the channel, and click the bell to make sure you're notified of new videos as they're added. Also, please share and comment below.